Victoria St. Martin, a young breast cancer survivor, and I am excited to be a part of the Alamo Breast Cancer Foundation Advocacy Chat on behalf of Young Survival Coalition. Today, we are talking about fertility in young adults with breast cancer. We will start with a presentation about fertility counseling and preservation in women with breast cancer from Dr. Terri Woodard, and then I will share my story. Dr. Terri L. Woodard is an associate professor in the Department of Gynecological Oncology and Reproductive Medicine and the director of the Oncofertility Program at the University of Texas MD Anderson Cancer Center. She also holds a joint appointment in the Division of Reproductive Endocrinology and Infertility at the Baylor College of Medicine. Her Oncofertility Program offers comprehensive fertility and building services to men and women who have been diagnosed with cancer.
Thank you for having me, and thank you for such a lovely introduction. Again, my name is Dr. Terri Woodard. I'm here to talk to you about preserving fertility, preserving hope in young men and women with breast cancer, but mostly women. I am so excited to talk about this topic. It's something that I'm very passionate about. It's near and dear to my heart, and hopefully I can adhere to the time limits for this topic because there's so much to talk about. So the objectives of my talk today are to talk about the importance and relevance of fertility issues in reproductive individuals with breast cancer, and to talk about some of the risks associated with breast cancer treatment, as well as examine options for fertility preservation and family building before and after cancer treatment. So we know that breast cancer is the most common cancer diagnosed in women, and over 230,000 new diagnoses of invasive breast cancer occur per year in the United States. And more than 5 to 7% of new breast cancers are diagnosed in women under the age of 40. And for many of these individuals, they may not have started or completed their family building plans. Fortunately, the 5-year female cancer survival rate is dependent on the stage of diagnosis, but is currently along the lines of 90% for breast cancer, thus making life after cancer and survivorship issues of utmost importance. However, the literature does show us that very few of these individuals actually go on to have a pregnancy. So why is all of this important? Well, we have literature that tells us why. We do know for a fact that survivors do want to have children, and their preference is to have their own biological children if possible. We also know that cancer-related infertility is a significant cause of emotional distress, and that sometimes this distress lasts more or longer than the distress associated with the cancer diagnosis itself. Counseling is also important because it's a tenet of holistic and comprehensive care. People should understand what their risks are before they're treated so that they can make informed decisions about fertility preservation. And it's simply the right thing to do to have these discussions early and upfront. So I'm not going to read this in detail, but ASCO, the American Society of Clinical Oncology, developed some recommendations about fertility preservation in cancer patients, first in 2006. These recommendations have been updated multiple times over the years, but essentially it puts the responsibility on all of us who care for patients with cancer to A, inform them of their risk, B, let the patient know that there are options that are potentially available to them to preserve fertility, and C, refer these patients who are interested in these types of options to reproductive specialists so that they can do those. And those discussions and referrals should happen as early as possible during the treatment planning of the patient. So what are the threats to fertility? Well, it depends on age, particularly for women. It also depends on someone's baseline fertility status. When we consider that infertility affects about 15% of the population, there's nothing to say that that woman sitting in front of you is not part of that. And it also depends on the treatment. So surgery to reproductive organs, which typically doesn't happen for women with breast cancer unless they might have to get an oophorectomy because they carry a genetic mutation that causes a predisposition to ovarian cancer. Radiation to the breast is not a problem because it's really to the pelvic organs where we get concerned. But chemotherapy and endocrine therapy are both things that can impact fertility. Chemotherapy in the sense that it directly damages the ovary by destroying some of the ovarian follicles that contain the eggs. And endocrine therapy, while it's not directly toxic to the ovaries, most of the time women have to be on these agents for 5 to 10 years. And in 5 to 10 years, they're older and their fertility is declining over that time. So here's just a list of some of the common chemotherapy regimens that occur in the care of women with breast cancer. Certainly, depending on age, some of these are more high risk than other risks. And of course, we know that in cancer therapy and therapeutics, there's more and more new agents all the time. I will say that a lot of women are being considered for like targeted therapies, immunotherapy, where we simply don't have data. We think those are not quite as bad as some of the traditional chemotherapy regimens that contain things like cyclophosphamide. But again, the patient should know that we don't know the risk. And if there's something that they want to do to lessen their risk, we should be helping them do this. Now I want to talk a little bit about what we do in our counseling. One is to educate patients about the impact of age on fertility. And this is a little graph of the Hutterite population. It shows that basically most of us, or all of us, are pretty much fertile when we're probably not thinking about having kids. And we hit that age about 35 years and that fertility declines more drastically. It's not impossible, but it's harder to have a live birth as we get older. One of the things that we do when we're counseling young women with breast cancer about fertility preservation is try to figure out what their ovarian reserve is. And ovarian reserve is the capacity of the ovary to provide eggs that are capable of fertilization that can result in a healthy and successful pregnancy. And we test this kind of indirectly because the only true way to test it is to have a baby. But there's some hormones to draw on day 3 of the menstrual cycle. This has kind of fallen out of favor because now we can test a hormone called antimone. It gives us an idea of how many follicles a woman might have in her ovaries and how she might respond to fertility preservation treatment. And we also do an antral follicle count, which I'll show you next. So antral follicles are the small little follicles that we can see in the ovary, and we at least 10 of these little follicles between the 2 ovaries. On the left, you see a picture of a nice ovary with nice healthy follicles, and on the right, you see one that really doesn't have a lot of follicles, and that tells me that this person might not respond well to fertility treatment. So to move on and talk a little bit about fertility and family building, I like to think about it this way. You can think about your options before treatment, which is true bona fide fertility preservation. And you can also think about things that you can do after treatment, which is working with what you have. And when I first started doing this, my focus was always on the before. I thought it was all fertility preservation. But I quickly learned that about 30% of the patients that come to me say, hey, I didn't have the opportunity to do this. I didn't have these discussions. What can we do now so that I can build my family? Here I've outlined the different options for fertility preservation just in general, not necessarily unique to cancer or breast cancer patients. But the ones in red are the ones that are relevant to patients with cancer. So we have assisted reproductive technology, which includes egg and embryo freezing. We have ovarian tissue freezing, and we have ovarian suppression. And these are the things that are typically authored by a reproductive specialist. And I will go into each of those a little more thoroughly in the next few slides. So I'm going to give you IVF in a nutshell. Basically, when we're doing IVF or egg freezing, basically what we're trying to do is get the ovary to do what it normally does each month to the 10th power. So instead of just recruiting one follicle, hopefully we'll recruit 10 or 12 or 14 follicles. And we do that by giving something called gonadotropins, which are strong fertility medicines that stimulate the ovary to recruit multiple follicles. Women take these injectable medications over the course of about 10 to 12 days for most people. And during that time, she's asked to come in several times for monitoring by ultrasound and blood work to see how we have to adjust her medications. Once we look and see that she has a good number of mature looking follicles, we'll give her a trigger shot that gets her ready to ovulate. But before she actually ovulates on her own, we will put her under anesthesia and do what's called a transvaginal oocyte retrieval. And during this time, we're able to basically suck the fluid out of each of these little follicles. And then that fluid is an egg. And that egg can either be frozen for patients that might not have a partner, don't want to use donor sperm, or those eggs can be fertilized with sperm to create embryos, which can then be frozen for later use. And just to give you some idea, this whole process takes about 12 to 14 days for most women. So what are some of the special considerations we must think about when taking care of patients with breast cancer? So of course, the first thing is the health of the patient. She has to be healthy enough to go through this. And this doesn't mean she can't have the conversation about family building, because we do have patients that might have advanced cancers and may have frozen things before and use things like gestational carriers to carry a pregnancy. But we do want to be safe when we do these procedures. The other thing is timing. So a lot of times I'm told by the oncologist, okay, we want to start chemo in 3 weeks. So how can we get this going? And traditionally, when we did IVF cycles, we'd have to wait for a period, which for whatever given patient might be 4 to 6 weeks. Fortunately, we figured out that we can do random starts protocol. So literally you can start a cycle at any point in the menstrual cycle. So I've had patients where I've literally started them the same day and they were done in 12 days. There's also the option if the patient has time to do back-to-back cycles so that they increase their yield of eggs or embryos. The other question that a lot of patients ask me about is the safety of this. They're thinking, I have breast cancer, I have an estrogen positive tumor. You're telling me that you're making my ovaries work in overdrive and there's going to be a lot of estrogen around. And that's typically the case. However, we have also learned that we can use certain medicines like letrozole or tamoxifen to try to keep those estrogen levels down. And remember, this is a short period of time. We usually think it's the chronic estrogen exposure that's a problem, but we do use these drugs to try to increase the safety measure. And the other thing is one very untoward side effect or complication of IVF or egg freezing is something called ovarian hyperstimulation syndrome. And that's where the ovaries like our meds too much, and someone hyper responds and can get very sick. They can get fluid around the lungs, the liver, they can throw blood clots. And of course, we want to avoid that because that patient needs to be ready to go to chemo as soon as possible. So a lot of times we'll use a special type of trigger that will help us avoid that. The other consideration is that many women, or I should say a significant number of women, will have a hereditary cancer syndrome that in a minute I will talk about how we can deal with that. But I think the most important thing to discuss with patients is to really set realistic expectations. A lot of times people want to refer to this as an insurance policy, but that is not the case. With insurance, if your house burns down, it will be replaced. You will get money. With this, we cannot guarantee a pregnancy. This is just an additional opportunity that will hopefully improve one's chances to have a baby in the future after cancer. So talking a little bit more about the hereditary cancer syndrome. So one perfect example, particularly with breast cancer, are those who are BRCA carriers. And there are a few different things that we think about in this patient population. So there is some data that suggests that these women have decreased ovarian reserve. This data is very mixed. I feel like it's very age dependent. So in older women with BRCA, I think you're more likely to see more differences than someone who's younger. The other issue is that these women are going to be recommended to have a risk-reducing bilateral salpingo oophorectomy, which is the removal of ovaries, typically by age 40-ish. And so in those cases, I've had women who said, yeah, I'm ready to get my ovaries out, but I don't want to close the window or door to potential biological parenthood. So we might freeze eggs or embryos in that situation. And then, of course, a lot of carriers are concerned that they're going to pass this gene along to their children. And a lot of patients, say, hey, I'm not going to have a baby if they're going to have to go through what I have to go through. And then others are, fine with it, saying, hey, in 20 years, we might have ways to deal with this, and my child will never have to worry about it. But what we can offer is something called pre-implantation genetic testing. So this is a picture of a day 5 or 6 embryo called a blastocyst. So it started to differentiate into its different components. So this is the inner cell mass, which is going to eventually become the fetus. And this is what's called the trophectoderm, which is going to become a placenta. And here you see an embryologist using a little biopsy tool to take some cells from the trophoblast. And with those cells, you can test to see if this embryo has the normal number of chromosomes, so it can pick up things like Down syndrome, trisomy 18, and it can also tell us the sex of this particular embryo. The other thing it can do is test to see if this embryo carries the BRCA mutation. And patients can choose not to transfer the embryos that have that. And again, this is a very personal decision. I feel like our job is to let patients know that this option exists, but I will say that the response to this is very mixed, and patients have to make that decision for themselves on whether to utilize this technology. Now I'd like to talk shortly about ovarian tissue cryopreservation. This is another fertility method that is no longer considered experimental as of about a year or two ago. This is good for women who don't have time to do IVF. They might not have the 2 weeks, and it involves a 1-hour outpatient laparoscopic procedure where we remove a portion of the ovary or the entire ovary. And what we do is take that ovarian tissue and shave off the cortex that has all those immature follicles. And if the patient becomes menopausal post-treatment, we're able to put that tissue back into her body, and it can regain function, and she can potentially get pregnant from this. Worldwide, we're probably up to about 180 live births resulting from this. There are some limitations in that, someone who has a BRCA mutation, obviously we're not going to want to put ovarian tissue back into that patient. There is also some evidence that this can be done even when a patient is prior exposed to chemo, though that patient should be pretty young if that's the case. And they've even done this in patients who've had leukemia. So you will be seeing more about ovarian tissue freezing. However, it's usually not the first step. We usually try to do egg or embryo freezing if possible. The other fertility preservation option is ovarian suppression, which is the use of gonadotropin-releasing hormone analogs to basically put the ovary in a quiet state, with the thought that an ovary that's not actively cycling is more resistant to chemo than one that is. And this is considered experimental for fertility purposes, but a lot of times we can get insurance to cover it by calling it menstrual suppression during therapy. This is a very controversial topic. You will see data that suggests it works. You will see data that suggests it doesn't work. However, there was a study that was done in triple negative women that showed that women who got ovarian suppression reported more pregnancies and ovarian function than women who did not. Now, it's important to note that the study was not designed to answer the question of whether this works for ovarian suppression and fertility and live birth, but it was an observation that I think took hold. And a lot of times we'll say, well, hey, the overall risk is low, so if a patient can't do anything else, why not go ahead and do the ovarian suppression? So we do offer it. So I want to talk just briefly about fertility and family building after cancer treatment, because I do believe women have a window of opportunity. I encourage women to be proactive, talk about this. A lot of times we will follow up with them about a year after they've completed therapy to just see where things are at and what the options are. And really, the options can range from natural conception. And one thing I've learned is that young women are resilient. I've had women that have minimal follicles, their tests look terrible, and they get pregnant with twins on their first IUI. It happens. So I think the key is being proactive and finding out what your options are. Some patients will need assisted reproductions, whether it's like ovulation induction with IUIs or intrauterine insemination, IVF. I have a decent number of patients who opt to use donor eggs and embryos if they have experienced ovarian failure. And then I also have a number of patients who don't want to take any risk in terms of becoming pregnant, although the data surrounding pregnancy in women with a history of breast cancer is very reassuring for selected patients. They use gestational carriers because they just don't want to be worried. And then, of course, adoption is always a great option for patients who are open to it. I will say that adoption can sometimes be difficult for cancer survivors because sometimes when they're screened, they're saying that, oh, this patient has cancer, they're not a good candidate to be a parent. And I think we just need more education telling people that people live after cancer now and they live long lives, and they're just as capable as being good parents and worthy of being good parents. So I always tell patients who are considering adoption to let them know that up front and ask, is this going to be a problem before they spend a lot of time and energy and money working with an agency. So in conclusion, hopefully I've convinced you that fertility is an important issue that should be addressed in patients with breast cancer and all cancers for that matter. We do have many viable options for fertility preservation that exist, and that they can be done in a safe and timely manner, and that family building options are also available post-treatment, and advocating for yourself in this area is priceless. Thank you. Victoria, I know this is something, obviously, I know we've just met and I've already learned so much about you in terms of, you have a little one, and we know that this is a very important topic to you. So we would love for you to share your story. I would love to hear it.
Thank you so much, doctor. I was 30 when I was diagnosed 10 years ago. And at the time, they said it would be virtually impossible to have a baby naturally with my chemo. So before chemotherapy, I did IVF with my then boyfriend, now husband. And it was funny. I remember that first time when I actually did have chemo. It's funny you mentioned insurance policy. I knew it wasn't, foolproof, but I do remember sitting in chemo and being like, okay, I'm doing something. I did something. And I know I was so lucky, and not everybody gets the chance to do it. I only had 2 weeks, right? But of course, not everybody gets the chance to do it. I remember after the fact, we had some conversations about, what are we going to do next? And, how will we build a family? Because I think we always knew we wanted to build a family together. And I want to say, let's see. So 9 years after I was diagnosed, I was just feeling sick one day. And I was like, oh, I actually thought I was going through the change because I had spotting. And I said, well, maybe I'm going through the change. I don't know what's going on. And then I took a pregnancy test and I was negative. And I was like, of course, why would I be pregnant? I mean, I didn't no, there's no way. And I was like, I don't know. And then maybe a week later, I took another test and it was positive. And and my little girl was born January 2020. So So yeah, it was one of those things where she's just the ultimate surprise. And I think overall, I my journey, it led me down different paths and ultimately to the path of motherhood, which is what I wanted, what I always wanted. Um, but I'm just so thankful and so grateful to have had these conversations about fertility preservation and about kind of what could happen. I think I feel that way. I feel that it's something that we don't talk about enough. I think when people talk about young women and breast cancer, they don't realize. I just had a Lyft driver. Like they were like, wait, what do you mean? How does that impact your fertility? And I'm like, a woman is born with all of the eggs she'll ever have. Um, I could see my baby girl's eggs on the ultrasound. Like, yeah, like, and so, I think everybody doesn't want to talk about it all the time, but I think it's good that we're having these conversations, and I think we need to have more of them, so that people know, and so that young women know, and so that they're not that they can plan their families, and that they can um, be moms if they want to be. So, yeah.
It sounds like you must have had an awesome oncologist. I mean, did they bring up the question or did you bring it up?
So it was funny. They did bring it up. And they said, you were going to freeze your eggs and you're going to freeze your eggs now. And I was like, oh, what? And I think the funny thing was, well, I had, every time someone mentioned my eggs, like, we talked about, my breasts and reconstructive options and this, that, and the third, and different types of surgeries. And every once in a while, somebody would say something about my eggs, and I was like, "What?" And I actually could not talk about my eggs without like bursting into tears because I didn't know. Right? I was ready to do whatever it took to stay alive, and I was ready. I knew that breasts were a part of breast cancer, but I had no idea that it would impact my eggs. So at first, I just burst into tears whenever anybody would mention it. But my oncologist mentioned it, and actually a girlfriend of mine who I met through YSC actually called me as well and kind of mentioned it to me too, like, you're gonna have to go. This is really, really important. You should do this before you have to do chemo. So we waited. I had to after I had a bilateral mastectomy, and after my mastectomy, we had like a window of time, about 2 weeks, that I ended up doing IVF. And it was a whirlwind. I mean, I know but it made me focus on the future, which I'm really glad that I did it, and that my doctors encouraged me to do it, because it helped me to focus on the future and where I was going instead of like what was happening to me now. I knew in the future I wanted to be a mommy. And no, I'm getting emotional, but I knew that then, so it helped me like get excited about, what could come, instead of what was happening to me, right then and there. So yeah, but yeah, my oncologist mentioned it. So yeah.
And you mentioned that you were fortunate that you were able to do all this. I mean, there are a lot of people that would love to do it that have the time, but obviously financially. I mean, do you run into that when you talk to people and they say, hey, I was really interested?
I do. I meet a lot of young women who, yeah, whether it's a financial or just time, I think the stories that make me the most upset are when doctors are like, oh, you wanted kids like in the middle of like chemo, and they're like, what? I mean, and I know women who like, yeah, like didn't have any children at all, and they say that to them, and it's like, oh, it's heartbreaking. I think, it just heartbreaking. It just makes me want to cry to know that somebody's like, oh, that's, you really wanted that? Like, well, you might have some trouble now. And it's like, oh my God. Oh my goodness. I think one of those things that I love doing too is just to continually talk to young women who are diagnosed. If a friend of a friend is diagnosed, like they like email me or text me like, hey, my friend's diagnosed, can you talk to them? And I just love talking to young women like early on, because if someone doesn't mention it, I would love to be the one to just say, hey, you might want to think about this. But I think things are changing, and I love the work that you're doing. I think it's incredible that you're doing it. How did you even get into it?
It was strange. I actually was doing a lot of sexual medicine, and I was in Detroit, and there was Hermanos Cancer Center, and I saw a lot of breast cancer survivors, and I ended up doing REI fellowship, and it was just kind of a natural marriage, because it's these quality of life things that they don't really address as well, but it all goes together. And then I was like, you know what, I really like this. So I kind of just started carving out this niche, and MD Anderson wanted to start a program, and I came. But I just love the patients. I love working with people. I like being a glimmer of hope, like in the midst of everything else. Like you said, someone sent you to talk to me because they believe you will live, right? You're going to have life after this. And it's just such an honor to be part of that. And honestly, the IVF and having babies is the cool part, but I think the most important thing I do from day to day is the education, whether they do this or not, just giving the patient some agency in something that they just don't have a lot of control over,
Yeah. I mean, that's the whole thing about cancer, right? You have no control. You have nothing is you have no control. Everything's out of your control, but these are things that you can do to kind of feel in control, right? Like, cutting your hair, or, going and preserving your fertility. Like, these are things that it's almost like taking little pieces back for yourself. Yeah. And, I know one day I'm going to have like some serious conversations with my little girl. Her name is Elizabeth. I think already I have, mini conversations with her about, breast health and all of that. I know she's only 21 months old.
She's like,
but I know one day I'm going to have serious conversations with her. And I think it's just so important that, nobody's in the dark, like I want her to know everything that her mommy went through, and for her to be here, and for all of us. I think for all young women, I think it's just so key, so important to kind of, to have conversations. And like I said, I mean, I think it's like, it to me, it just brought hope back, brought life back, brought renewal back to me, even before I was, years before I was pregnant, right? Like it just made me think like this could happen one day, and like dream about that. At this time that, like I said, was just very dark, and like to be able to dream about like the future, which is everything. Like, I mean, my husband like makes fun of me, but like I was like so excited. You would have thought that like I just won the lottery or something, like, because I was just like, they're out and they're like, everything's gonna be okay. And like, he's like, oh my God. Yeah. So yeah. I don't know if I can share my screen, if I can share a picture of my baby. Let's see. Can I? Oh, I can.
Yay.
There she is.
She's beautiful.
Thank you.
My mother is a survivor. Yes.
Yes, she's my everything. She's my everything.
Yeah. Beautiful little girl.
Thank you. Thank you. We call her Lily for short. So Elizabeth, we call her Lily for short. So she's just my little kind of rebirth and renewal after all of this. So thank you so much, Doctor, for being with us today and for giving us all hope about life after cancer and being mommies and daddies after cancer. So I appreciate it.
And thank you for sharing your story. I think it, provides hope for a lot of other women out there that are facing or going to face the same thing you did. And, you know, it shows them that life does continue after cancer, and it can be quite sweet.
And it can be so sweet.